everyone. Now we'll discuss about lap cholecystectomy. I know everyone is aware of the topic, but in the exam point of view, what needs to be written? Just explain that. Laparoscopic cholecystectomy is the surgical removal of the gallbladder using a minimally invasive approach. It remains the definitive treatment for symptomatic gallstone disease. Indications of lap cholecystectomy: elective, symptomatic cholelithiasis, gallstone pancreatitis, choledocholitis, biliary dyskinesia, gallbladder polyps, porcelain gallbladder. Emergency, acute cholecystitis. Every lap chole within 72 hours or the index admission is a standard of the care. Acute cholangitis, ERP drainage first, followed by the lap cholecystectomy. Empyema, gangrenous cholecystitis. Asymptomatic generally require expectant management. Contraindications is absolute, unfit for GA, uncorrectable coagulopathy. Relative contraindications are the severe cardiopulmonary disease, suspected GB carcinoma, extensive adhesions, portal hypertension, cirrhosis, pregnancy, morbid obesity, and the Mirzzi syndrome. The preoperative assessment and the prophylactic protocols. Diagnostic domains: airway reserve, coagulopathy, sepsis, jaundice, adhesions, and obesity. The core lab workup: the full blood count, renal functions, LFTs, prothrombin time needs to be assessed. Guide for the anesthesia, assess for the obstruction and the infection. Cardiopulmonary assay, ECG, echo, chest X-ray, PAVU needs to be done. The prophylaxis protocols: antimicrobials, the second generation cephalosporin given at induction to reduce surgical site infection risk. Record the drug dose and the time. Thromboembolic risk needs to be reduced by usage of subcutaneous heparin and antiembolic stockings. Predictors of difficult cholecystectomy: history, male gender, age more than 65 years, symptom onset more than 72 to 96 hours in cases of acute cholecystitis, multiple prior attacks, previous upper abdominal surgeries, prior cholecystostomy. Physical examination: morbid obesity, high ASA score, American Society of Anesthesiologists score. Lab and imaging: abnormal LFT, thickened wall, GB more than 4 to 5 mm, contracted GB, distended GB with impacted neck stone, gangrenous GB or perforation, Mirzzi's or portal cavernoma or the cirrhosis. Intraoperatively, shrunken gallbladder, retracted liver edge with puckering near fundus, fatty or firm cirrhotic liver causing retraction difficulty. The risk stratification: the low risk 2 to 3% criteria: no history of cholangitis or pancreatitis, normal LFT, CBD diameter less than or equal to 6 mm on USG, no further evaluation is required. Medium risk 20 to 40%, history of cholangitis or pancreatitis, elevated LFTs up to 2 times normal, CBD diameter 8 to 10 mm. High risk criteria: history of cholangitis or pancreatitis plus overt jaundice, LFTs more than 2 times normal, CBD diameter of more than or equal to 10 mm. In low risk, no further evaluation is required. In medium risk, requires MRCP with or without ERCP stone extraction. In high risk, it requires same like the moderate, MRCP with or without the ERCP stone extraction. The operative room setup and the patient positioning: supine with steep reverse Trendelenburg position. Patient must be securely strapped. Arm placement: one arm is tucked to allow for intraoperative cholangiogram, or both arms are out per the surgeon preference. Adjunct placements: orogastric tube decompresses the stomach to optimize upper abdomen view. Foley is placed if prolonged operation and time is anticipated. Preparation: wide preparation of the abdomen and lower chest to accommodate open retractor system if urgent conversion is needed. Port placement and traction dynamics: at 12 mm periumbilical port for camera and extraction, 3 5 mm ports right anterior axillary line, right midclavicular line, and at the subxiphoid. Traction vectors: cephalad upward, lateral anterior axillary port elevates fundus towards the right shoulder to expose the porta hepatis. Introlateral, downward or lateral, mid-clavicular trocar retracts the infundibulum, the Hartmann's pouch. The opposing traction is crucial maneuver that opens Scallott's triangle for safe dissection and increase the angle between cystic duct and the common bile duct. In our institute, we use 10 mm port for the subxiphoid port, but as this has been given in Sabiston and the image is also from Sabiston, I have mentioned it as 5 mm only. You can do it as per your convenience. The anatomical mapping, the important triangles, the Scallott's triangle and the hepatocystic triangle. Scallott's triangle is the cystic duct, common hepatic duct and the cystic artery, and the hepatocystic triangle, the Woody-Rocco, is defined by the cystic duct, common hepatic duct and the inferior border of the liver. The hepatocystic triangle is a true area that must be cleared of all fibro, fatty and soft areolar tissue to achieve safety view. Achieving the critical view of safety. Step 1 is clearance of the hepatocystic triangle. All fibro, fatty and soft areolar tissue must be cleared. Step 2 is exposure of the cystic plate. The lower part of the gallbladder must be separated from liver bud to expose the plate. Step 3, only two structures must be seen entering the gallbladder, the cystic artery and the cystic duct. No structures are clipped or cut until all the three criteria are unequivocally met. The intraoperative tenets for safe cholecystectomy. Minimizing the risk of bile duct injury relies on strict adherence to structural identification protocol, controlled energy and cognitive stopping rules. The B-safe method and the anatomical landmarks. The B-safe method establishes 5 anatomical landmarks to map the operative field during dissection. B. Bile duct. S. Sulcus ruveus. A. Hepatic artery. F. Umbilical fissure. E. Enteric or the duodenum. The safe zone of dissection lies effluent to a line extending from the roof of ruveus sulcus to the umbilical fissure, crossing across the base segment 4. So that's the diagrammatic representation of the B safe zone or the R4U line. As described earlier, our dissection should always be above the R4U line, which is the safe zone. The safe usage of the monopolar core tenets of the cautery, the do's and do nots. Use low power, maintaining a low setting of approximately 30 volts to prevent current arcing to the bile duct. Intermittent use. Use short bursts of current to strictly limit lateral thermal spread. Mechanical safety. Divide small amounts of tissue at a time and apply gentle pull to avoid structural injury from heel to of the hook. Absolute risk. Avoid blind usage of cautery during the brisk bleeding. To do a safe lap cholecystectomy, the must follow 3 rules are acquiring the critical view of safety, operating above the R4U line in the B safe zone, and the break point. The cognitive rules should be known. The red flag should be recognized, that is loss of orientation because of the severe inflammation, and a timeout should be executed. The timeout triggers and the 5 bailout strategies. The trigger the red flags, failure of timely progression, anatomical disorientation, severe adhesions, acute inflammation, impacted neck stones and meresis. Then we follow a mandatory timeout, cognitive pause, stop the operation, recall safety measures and seek a second opinion. Step 1, abort, stop the procedure altogether if unsafe. Step 2, convert to open. Do this by choice early, not as a reaction to a complication. Third, tube cholecystostomy, 14 French Foley catheter for symptomatic decompression. 4. Subtotal cholecystectomy, leave part of the gallbladder behind to protect the hepatocystic triangle. Step 5. Fundus first, dome down, alternative dissection approach can be followed. Sometimes intraoperatively we need to proceed with the biliary imaging. We can do intraoperative cholangiography or the fluorescent cholangiography. The indications are the gallstone pancreatitis, anomalous anatomy, suspected choledocholithiasis, guiding biliary reconstruction. In intraoperative cholangiography, ductotomy in cystic duct and is done and a water soluble contrast is injected which opacifies the biliary tree under live fluoroscopy. In fluorescent cholangiography, IV indocyanine green dye of 800 nanometer absorption which binds to plasma, is excreted in bile, fluoresces green under the non-infrared light. Real-time mapping without ductotomy can be done. The safety indication: it is safe in pregnancy, ultra-low anaphylaxis, avoid severe shelf life or iodine allergy. It can be visualized in 10 to 15 minutes or 2 to 4 hours. The common bile duct exploration (CBDE) single stage CBDE during lab cholecystectomy offers equivalent clearance to two stage ERCP with low cost and shorter stays. The transcystic approach is preferred. Indications or the contraindication: it is technically easier. Avoid if the more than 8 stones are present. Stone size is more than 1 centimeters. Intrahepatic stones on the narrow tortuous duct is noted. Technique: Seldinger technique via cystic duct, balloon dilatation of 6 to 8 mm to lyse walls of hyster, stone capture via basket or flush into duodenum. Transcholedochal approach and the lap cholecystectomy. Indications: large stones more than 1 cm or failed transcystic retrieval. The technique: longitudinal incision directly into the CBD. Uses electrohydraulic lithotripsy. Requires direct stone contact. Closure: primary closure using 4-0 absorbable for ducts more than or equal to 1 cm. Close over T-tube for small ducts or stricture concerns. Requires complete cholangiogram. Finalizing the procedure: division and extraction. Clipping and division: cystic artery is clipped and divided, then cystic duct is clipped and divided only after critical view of safety is confirmed. Gallbladder is removed by dissection. Gallbladder is separated from the liver fossa using electrocautery. Crucial detail: the cystic plate is left attached to the liver to avoid bleeding from liver sinuses and prevent bile leaks. Extraction and the hemostasis: it is extracted through the epigastric or the umbilical port using a specimen retrieval bag. Irrigation and final hemostasis check is done and the procedure is completed. Ambulatory pathway: discharge, day case. Uh, if the standard of care for uncomplicated and elective cases of ASA 1 to 2. Analgesia and pain: multimodal, paracetamol and NSAIDs, and the opioids can also be given. Shoulder tip pain: referred pain via phrenic nerve from residual CO2. It resolves in 24 to 48 hours. Diet and activity: clear fluids 2 to 4 hours post-op, light diet same day, low fat diet for 2 to 4 weeks, driving or desk work in 1 or 2 weeks, manual labor in 4 to 6 weeks. Drains or blood not routinely used unless bleeding, complex dissection or post-operative pain or jaundice occurs. Complications: the post-cholecystectomy syndrome, intraoperative and immediate. Intraoperative: bleeding, bile duct injury, bowel or the vascular injury, GB perforation or the spillage. Immediate post-op: bile leak, retained CBD stones, subhepatic collection and wound infection. Late post-cholecystectomy syndrome. Definition: the persistence or recurrence of symptoms in 10 to 15% of the patients. Biliary causes are the retained stones, duct stricture, cystic duct stump syndrome, sphincter of OD dysfunction diagnosed via ERCP manometry. The non-biliary causes are the inflammatory bowel syndrome, peptic ulcer, GERD, incorrect original diagnosis. Post-cholecystectomy diarrhea pathophysiology: it occurs in 5 to 10% of patients due to continuous unregulated bile flow into the colon. Loss of gallbladder storage. The treatment is treated with cholestyramine, a bile acid sequestrant. Thank you. Hope it was useful.